So Esper asked me to talk about activation and pathogenesis. And I've titled my talk, A Tale of Two CDs. So why focus on two CDs, CD4 and CD8 T cells in HIV infection? Why should one do that? Well, I had to go back into the literature and realize that many years ago, Archimedes told us that to a man with a flow cytometer, everything looks like a CD antigen. So this is actually pretty, I'm going to tell you two stories. I'm going to tell you a story about the CD4 T cell that plays an important role in immune function and immunologic failure. And then it's really neat that I followed Alan Landay's talk, because I'm going to talk about another cell that we think plays an important role in cardiovascular risk. That's the CD8 T cell. So CD4 cell numbers, as you know, are general reflections of immune health and predict the risk of opportunistic infections in the pre-antiviral therapy era. But in the current era, when we have antiretroviral therapies, these CD4 T cell numbers are predictive of non-AIDS morbidities, cardiovascular disease, malignancies, metabolic disorders. Now, what happens to CD4 T cells? We all know that when we start antiviral therapy, the numbers go up. And sometimes, but not as reliably, we see an increase in CD4 T cells in tissues, lymphoid tissues, and gut. The CD8 story is very different. There's a big dynamic in CD4 T cells, at least in blood, with antiviral therapy, but CD8 T cells are typically elevated in HIV infection. The numbers of CD8s expand, but with antiviral therapy, CD8 T cell numbers go down just a little bit, but they classically remain elevated. In the pre-ART era, before antiviral therapy, activation of CD8 T cells was a very reliable predictor of a morbid outcome, perhaps more reliable than some of the other indices we used. And in the antiviral therapy era, after the initiation of antiretrovirals, CD8 T cell expansion persists, as I told you, and a low ratio of CD4s to CD8s predicts morbid outcomes, non-AIDS defining outcomes in antiviral therapy-treated HIV infection. So I'm going to talk first about the CD4 T cells. These are the cells that move up and down. They drop with HIV disease. They go up with control of viral replication, at least in blood. But in some of our patients, CD4 T cell numbers do not go up. And when they don't go up, these people are at risk for morbid complications. So we wanted to look, and we've actually known for some time, that among the people whose CD4 T cell numbers do not increase, the frequency of CD4 T cells that are in cell cycle, meaning that they're thinking about dividing and making baby CD4 T cells, is increased. So on this slide, we have the frequency of cells that are Ki67 positive, meaning that they're in cell cycle now or just recently have been in cell cycle. This is in healthy controls. This is in people who are immune responders, IR. And these are people who are immune non-responders, INR. And you can see these numbers are elevated. We've demonstrated this 7 years ago, and other groups have found the same thing. This is in another cohort showing exactly the same thing as we saw earlier. Now, the proportion of cells in cycle, that is the frequency of CD4 T cells that are Ki67 positive, is inversely related to circulating CD4 T cell count. So the higher your circulating CD4 T cell count, the lower or more normal your frequency of cycling cells is. If the CD4 T cell count is low, cycling frequency is high. So what is this? What does that really mean? Well, it's not clear. Many have argued that the high frequency of CD4 T cells in cycle is a reflection of a homeostatic response to lymphopenia, meaning you don't have enough CD4 T cells, you want to make more, so you make them divide, you make them proliferate. On the other hand, the alternative hypothesis is that the high frequency of cycling cells is a reflection of failed immune homeostasis, the inability for these cells to divide, or maybe even a driver of excessive CD4 T cell cycling, cell turnover, and death. So we wanted to look into this, and that's what we did, and that's what I'm going to talk to you about. We decided we wanted to interrogate the transcriptional profile of CD4 T cells that are in cycle. Now, before recently, we weren't able to do this reliably because in order to measure cycling and by expression of Ki-67, you have to permeabilize the cells. And if you permeabilize the cells, it's hard to recover good quality RNA from them. So if you want to do a transcriptional profile on sorted cells, then you need a cell surface marker that reflects cell cycling. And Suhail Yunus, who is a postdoc in my laboratory, has identified such a marker that works well for CD4 T cells and CD8 T cells. And that marker is the transferrin receptor, CD71. And you can see on the left panel, whoops, not good with this, so sorry. On the left panel, we have CD71 on the y-axis, Ki-67 on the x-axis, and you can see that the cells that are Ki-67 high are CD71 high. And if you look at multiple samples from multiple individuals, there's an exquisitely tight relationship between the proportions of cells that are CD71 positive and Ki-67 positive. I should tell you, and I didn't yet, should warn you that the cycling cells that we see in circulation are not naive cells, but they're memory cells, and some of them are central memory, and a good number of them are more differentiated effector memory cells. We don't see a lot of cycling in peripheral blood. Among naive cells, that's presumably taking place in lymphoid organs. Just to confirm that this marker of cycling is a good marker of cycling, we show here in the three populations, controls, immune successes or immune responders, and immune non-responders. In green, we have the CD71 negative cells. In purple, the CD71 positive cells. We see upregulation in the CD71 positive cells of all the transcriptional elements that are associated with cell cycling. So CD71 sorting on CD71 expression reliably identifies cells that are in cell cycle, and that's the case for each of the three populations that we see here. Now, when we sorted these cells on the basis of CD71, we sorted the CD71 negative cells here, and we labeled all of these cells with CFSE, which is a fluorescent dye, such that if you put these cells in culture, the cells that divide will divide the intensity of dye, and so the dye intensity will move to the left as the cells divide. Not surprisingly, among the CD71 negative cells of each population, controls, immune responders, and immune non-responders, after 1 week in culture, there's really no dilution of dye. All these cells have as much CFSE as they started. However, among the cells that are in cell cycle that were sorted, cell cycling cells, CD71 positive cells, after a week of culture, there's nice brisk dilution of dye, and these cells are not stimulated. They're just set in culture. And this tells us that these cells that are identified by the presence of this antigen, CD71, that tells us they're in cycle, are capable of proliferation ex vivo. They proliferate fine among the healthy controls. They proliferate fine among the immune responders. However, the immune non-responders, and again, these are all cycling cells that express markers of cell cycle, are not capable of ex vivo proliferation. In fact, they die. Many of them die. Now, this really surprised us. We didn't expect this. We expected that them to die. That was not a real surprise. But when we phenotyped the cycling cells, what was amazing to us is that the cells that were in cycle were dramatically enriched for cells with the phenotype of T regulatory cells. By that I mean CD25 positive, that's IL-2 receptor alpha chain, CD127 and negative, that's IL-7 receptor alpha chain, and transcriptional factor FOXP3 positive. That's what we see on the on the y-axis, which I'll point out is in a log scale. These are our healthy controls. These are the frequency of these cells that are CD71 positive, CD71 negative, total CD4s. And these are all memory cells again. As I mentioned, the cycling cells that we looked at are cells in the memory compartment, and we see the same enrichment, similar enrichment in the HIV positive patients for FOXP3 T regulatory cells, and likewise in the immune non-responders, although the magnitude of the enrichment is less in these folks than in those. Importantly, in each of these populations, healthy controls, immune responders, immune non-responders, the cycling cells, shown in purple, are enriched for expression of a T regulatory cell signature. That's seen in each of the three populations. However, when we compare them, and here it's the same, it's similar data, we have different profiles here. We have the profile of the regulatory T cell signature that you saw before, and FOXP3 upregulated targets that are increased in expression among cells that have a regulatory function. We have each of our patients in these populations shown in groups here, with the healthy donors in orange, the immune responders in green, and the immune non-responders in red. You can see that there is poverty of expression of these regulatory T cell signature genes and FOXP3 upregulated targets. So although they're enriched in the cycling cells of each population, the magnitude of expression is lower in the immune non-responders. So, just going to summarize the data as to where we are now in this first half of the talk. Cycling of CD4 T cells is increased in antiviral therapy-treated HIV infection, and it's inversely correlated with absolute CD4 T cells. This is primarily in immune non-responders. In immune non-responders, the cycling is ineffective in that the cells will not proliferate and successfully divide ex vivo, and there's an increased frequency of cells that bind in exon 5, meaning that they're considering dying. I didn't show you those data, but they're there. What I've shown you as well is that the cycling CD4 T cells are enriched for cells with phenotypes and signature of T regulatory cells, but both phenotypes, their signatures, and the targets of FOXP3 are diminished in the cycling CD4 T cells of immune non-responders. So the question is, does T regulatory cell failure underlie the increased activation and inflammation that we see in immune non-responders, or alternatively, is it possibly a consequence of it? We can't say so from these data, but we're interrogating some of the functional aspects of these cells as we speak. But I think one thing we can say, and I think we can say this comfortably, is that the increased CD4 T cell cycling in immune non-responders does not appear to be a homeostatic response to lymphopenia in this population. I think that's the question we set off to answer, and I think we did answer it. Okay, I'm going to switch gears to the second CD, and that's CD8. So I'm going to talk to you about the role of CD8 T cells in non-AIDS complications of treated HIV infection. And as part of this, I'm going to implicate cytomegalovirus as a contributor to some of these outcomes. And this has been implied, suggested, demonstrated in a number of studies. And we're trying to figure out how this happens. How do CD8 T cells play a role in non-AIDS complications in the antiviral therapy-treated era? So what's the background? The background, as I mentioned earlier, I said this before, but I'm going to remind you again, with CD8 T cells expand in untreated HIV infection, and with antiviral therapy, those CD8 T cell expansion persists. Activation of these cells predicts disease outcome in untreated infection, but in treated infection with antiviral therapy, this expansion and a low CD4-CD8 ratio predict morbid outcomes in a number of studies. And in both the pre-ART era and in the current ART era, the presence of cytomegalovirus co-infection in the setting of HIV disease increases the risk of morbidity. Now, are these two things linked? Absolutely, and I'll tell you how. Last year, I talked about this, and I'm summarizing on this slide what I said last year. I can't remember it, so it's on a slide. Maybe you'll remember it, but what I showed you last year is that the cycling of memory CD8 T cells was increased in untreated HIV infection. And the frequency of cycling normalized, but with antiviral therapy, but the expansion did not. Those numbers stayed high. And we showed you some data that have been published since that indicate that the expansion of CD8 T cells in chronic HIV infection is largely sustained by bystander mechanisms, that it's not driven by looking at antigens, it's not driven by T cell receptor stimulation. And the reason we can conclude that, the data I showed you last year, was that the structures of the V beta chain of the T cell receptor, as recognized by panels of monoclonal antibodies, were superimposable in the cycling cells and in the non-cycling cells. And the other thing that I showed you last year was that the sequences of the T cell receptors of the cycling CD8 T cells and the non-cycling CD8 T cells, the distribution of those T cell receptors sequences was also the same. So something was driving the cycling of all memory CD8 T cells in untreated HIV infection, and it wasn't peptide. The cells that are matured are cytolytic potential, and we found out that this phenotype could be reproduced in vitro by exposure to interleukin-15, one of the common beta chain cytokines. And in vivo, we showed that the lymph node levels of interleukin-15 were increased and in HIV infection, and the levels of IL-15 in those nodes correlated very nicely with total CD8 T cell numbers. So in untreated infection, we're proposing that CD8 T cell expansion is largely a consequence of expansion driven by interleukin-15. But it turns out that there's another cofactor there, and that's the presence of cytomegalovirus. We don't see CD8 expansion in untreated HIV infection or in treated infection unless there's CMV co-infection. So the two coexist, the two do it together, CMV infection and interleukin-15 hyperexpression in untreated infection. So we had this model of cardiovascular risk that I showed you last year, and it's good that Alan talked about the monocytes, because we think the monocytes are really important. As Alan mentioned, Nick Funderburg, who was once in my laboratory but has left, and so his name can no longer be spoken aloud, showed a while ago, that monocytes in HIV disease express the procoagulant tissue factor that initiates the coagulation cascade that elaborates thrombin and ultimately a clot. At the site of the endothelium, where monocytes congregate because of expression of certain homing receptors, we propose that thrombin, elaborated by these cells, activates PAR-1, a thrombin-activated receptor, on the surface of CD8 T cells, activating these effector T cells and allowing them to participate in the formation of an atherosclerotic plaque. That was the model we were proposing. Is it true? Well, maybe so, because in the SIV-infected rhesus macaque, Shomo Panigrahi was able to show that monocytes and CD8 T cells accumulate in the vascular endothelium in SIV or SHIV infection. And here you can see CD8 T cells in the endothelium, CD68 positive monocytes, and the two of them close together. And we see that in the SHIV infected animals, there is an accumulation of inflammatory cells that's not seen in the uninfected animals. And here are the summary data of the animals that are SHIV or SIV infected for inflammation with CD8 T cells, accumulation of those, as well as inflammation and accumulation of monocytes. So the question is, I'm not going to talk about the monocytes this time, talked about them a little bit last time, but I am going to talk about the CD8 T cells. How do those CD8 T cells get there? Well, we think they get there in large part by expression of the fractalkine receptor CX3CR1. And on this slide, we show that CD8 T cells will express fractalkine receptor. It's not expressed on CD4 cells, and it's expressed with greater frequency as CD8 T cells mature from naive to terminally differentiated cells. These cells are circulating CX3CR1 positive CD8 T cells are expanded in HIV infection. They're expanded in HIV infection. They're excluded from lymph nodes but found inside the blood. And their frequency is related to the CD4 CD8 T cell ratio, such that the lower the CD4 CD8 T cell ratio, the higher the proportion of CD8 T cells that are CX3CR1 positive. And we know that this low CD4 CD8 ratio is linked to a greater risk of cardiovascular disease. So we're having some inferences here that suggest that they may be linked at some level, or at least correlated at some level. I show on this slide that the cells that are fractalkine receptor positive, CX3CR1 positive, express PAR-1, the thrombin-activated receptor, more frequently than do the CCR7 positive cells. These are the fractalkine receptor positive. And in the HIV positive population, whether the cells are CCR7 positive or CX3CR1 positive, they're more likely to be reactive or activated or express a receptor that can be activated by thrombin. And if you're CMV seropositive, if you're HIV positive, if you're CMV seropositive, you have a greater frequency of cells that co-express CX3CR1 and PAR-1. So HIV increases your frequency of these differentiated cells that have a thrombin activatable receptor, meaning can be activated by the formation of a clot. And if you're CMV seropositive, that frequency increases even more. What about the CMV-specific CD8 T cells? So here we have exposed CD8 circulating blood cells to tetramers that recognize CMV peptides and that contain CMV peptides or influenza peptides. And you can see that the CMV reactive cells, the cells that recognize this particular CMV peptide, have a high frequency of cells that are CX3CR1 and also PAR-1. They are enriched for expression of both, more so than are the influenza cells. And here we see the summary data in the entire population. About half or so of CMV reactive cells have a receptor, a homing receptor on the surface that persuades them to bind to fractalkine that is expressed frequently on the surface of the endothelium. So this is a likely mechanism whereby these cells can get there, and once they're there, they have another receptor, they express another receptor that allows them to be activated by thrombin. So, I'm telling you a story, I'm trying to make a story that the setting of HIV disease and CMV co-infection makes it likely that CD8 T cells are going to end up in the endothelium near monocytes, where a clot may be forming. And the question is, how do these cells get activated? Well, one way they can get activated is by thrombin, by clot. But do they get activated at all by cytomegalovirus? Do they recognize CMV peptides that are expressed in vascular tissue or by cells that are near vascular tissue? Or perhaps is there another mechanism? The way I'm asking this question, I am proposing another mechanism, and here's where we're going. The reason that I think another mechanism is likely important for the activation of these cells is that these terminally differentiated cells only infrequently express CD28, which is the co-receptor for T cell activation through the T cell receptor. And here on this panel on the far right, you can see the CX3CR1 positive cells that are CCR7 negative frequently express CD57, but only infrequently express CD28. And in fact, the more differentiated they are, the more senescent they are, the lower the likelihood is that they're going to be expressing CD28. So if they're not going to respond very well to T-cell receptor stimulation because they're, quote, anergic, CD28 negative, is there another pathway? Well, maybe there is, and we decided to explore the CD2 LFA3 axis, and here's why. First off, CD2 is the SHIV erythrocyte receptor that is expressed on virtually all T cells. It can provide co-stimulatory signals when you activate via CD2. It can, literature tells us, it can provide co-stimulatory signals to T cells, and it's the major co-stimulatory pathway for cells that are CD28 negative CD8 T cells. Now, what's the importance of LFA3 here? Well, LFA3 is a natural ligand for CD2, and it is expressed on the endothelium. It's an endothelial marker. It's expressed on a variety of cells, but it is expressed on the vascular endothelium, particularly when these cells are activated. So we hypothesized that CD2 could provide a non-canonical, antigen non-specific route of activation of fractalkine receptor CX3CR1 positive CD8 T cells. First off, the density of CD2 increases as cells mature. So on the left panel, we have CD2 density in naive central memory, CCR7 negative, CX3CR1 negative, and on the bottom panel, CX3CR1 positive cells. And on the right panel, we show the summary data on a number of individual samples. As cells are more matured, their CD2 density increases. Whoops. Okay, thank you. Good. We can stimulate cells by stimulation via CD2 LFA3 axis. Yes? Did I lose it there? So we can stimulate cells via the classical pathway, T-cell receptor stimulation on the bottom here, to express interferon gamma or other cytokines, TNF alpha, MIP1 beta, or interleukin 2. But we can get a similar stimulation pattern when we stimulate via this alternative SHIV erythrocyte receptor anti-CD2 stimulation. This stimulation is T-cell receptor independent. You don't need to stimulate via antigen. You don't need CD3. And it turns out that not only can you induce a single cytokine by CD2 stimulation, you can induce multiple cytokines, 1, 2, 3, or with a low frequency, even CD4, although at least in terms of 4 cytokines, CD3 stimulation seems to be a little more effective. This is this panel on the far right shows us the patterns of responsiveness with CD2 stimulation versus CD3, CD28 stimulation, and you can see that a variety of cells in these populations are capable of elaborating different patterns of multiple cytokine expression. And this is very important here. Not only can you elaborate cytokines with CD2 stimulation, but by stimulation via the CD2 LFA3 axis, you can elaborate cytolytic molecules such as granzyme B as well as perforin. I'm showing you the granzyme B data here. And even more compelling is the observation that among HIV-infected people, the degree to which those cells will respond to LFA3 stimulation is greater than that seen by HIV-negative individuals. The HIV positives are in blue, the HIV negatives are in green. So, to summarize this last piece, intravascular events are complicated. CD8 T cells and monocytes, we believe, accumulate in the endothelium of SIV-infected rhesus macaques. It's harder to show that in humans with HIV infection, but we are assembling samples in which to evaluate this. I can't tell you anything yet about the human system. In HIV infection, the matured CD8 T cells express the fractalkine receptor CX3CR1, and these cells are excluded from lymph nodes, but they are capable of binding to the endothelium, which expresses the ligand fractalkine. These fractalkine receptor positive cells typically lack CD28 expression, meaning that they may not respond all that well to co-stimulation after T-cell receptor stimulation. In both HIV infection and in CMV co-infection, fractalkine receptor positive CD8 T cells are enriched for the thrombin-activated PAR-1 receptor, which means that they can be activated to elaborate mediators via activation of the coagulation cascade. Alternatively, we can stimulate these fractalkine receptor positive cells through the CD2 LFA3 axis that induces a very robust cytokine response that includes the ability to be cytolytic or toxic to nearby cells such as endothelial cells, which is what we're proposing. And so we're asking the question as to whether non-canonical activation of CD8 T cells is an important contributor to cardiovascular risk that is seen with the greatest frequency in HIV-infected, CMV co-infected persons with CD8 T cell expansion and maturation. So if anybody invites me here next year, maybe I'll tell you more about that story by then. So I want to thank the large number of people who've done this work. The bulk of the CD4 T cell T regulatory work was done by Suhail Yunus, who is a postdoc in my laboratory. The CD8 T cell work was done by Mike Freeman, who was a postdoc in my laboratory but now has a junior faculty position. The other folks here at CASE are collaborators or grad students of mine. I've neglected to list the name of the person whose name cannot be mentioned, who did the monocyte work. I didn't present the monocyte work, but that's Nick Funderburg, as Alan mentioned to you, who's now at Ohio State. Many of the samples that we studied in the T regulatory studies were provided by Konstantin Schmegel at Perm State University in Russia, and we have collaborators at UCSF, Drexel, NCI, Emory, NIH, and University of Minnesota. The systems biology work was led by Arthur Talla, who works in Rafiq Sekali's lab at Case Western Reserve University. And I have a position open for a postdoctoral fellow. So, could be a Brazilian postdoc. Your name could be here. So thank you so much for your attention.